By the people, for the people, the gathering to get health care now. Chapter 17, Medicare Advantage. When Medicare Advantage plans began, some physicians told their patients they were not going to take Medicare. If the patient wanted to continue to be seen, he or she had to join the Medicare Advantage plan that contracted with the practice. Some practices in Houston formed their own HMOs, and they still use this tactic. It was and still is a very effective enrollment method. Often the HMO does not use agents but enrolls patients using salaried staff. When the numbers of physicians were few and there was a risk-sharing agreement between the plan and the physician, the programs worked okay. As the ambitions of the health plans and the physicians grew, the numbers of physicians listed for the plans became huge, and the cost grew both administratively and medically. The bigger the network, the looser the controls on administration, hospital, and diagnostic costs. The plans tried to solve this utilization control problem by more automation and more detailed reporting of encounters between patients and medical and hospital providers. The doctors that moved their patients wholesale into a plan found that instead of making a profit, they were paying the health plan for hospital and specialist costs beyond any network or facility they personally would have approved. All of this was before the 2003 rate increases and the change in reimbursement based on morbidity. But the experience among physicians was widespread and negative. Now it's almost impossible to get one of those physicians to move his or her patients to a plan and take the risk of paying for the care. Both CMS payment amounts and risk-bearing agreements have changed. Risk has been spread among more physicians, financed by the health plans, and budgeted over longer time frames with stronger reserves set aside for potential large claims. Also, risk-taking is not done unless there's a whole team of physicians working for a patient population and the patient services can be kept within the team. The intention is about caring for patients. This requires resources that match task. People should avoid needless help in the delivery of health care, in the enrollment of patients, and in the use of equipment and facilities. It's a communication from a trained staff of physicians and their patients that sets up the member enrollments. Home visits with each of the patients. Now, suppose patients enroll in plans that are economical and beneficial for both the patients and the physicians. Suppose, further, that the people in your organization get to know the patients well and really want to relieve suffering and stress. You can't get this idyllic relationship solely through mail or phone. You can't sit quietly at your computer and crank out memos to members with full color pamphlets that have generalizations about the most chronic diseases. The most common likely scenario for developing a good doctor-patient staff rapport will be through a comprehensive physical exam, after which the patient can get the advice and care they seek. And for 20% of the population who don't go to the doctor, the in-office visit is not the best medicine. The office visit does not relieve suffering and stress to the same extent as does the home visit. A home visit by a nurse did not seem very important until our company contracted with XL Health for our IPAs in Texas. XL Health was a special needs program that was assigned 15,000 Medicare patients who had one or more of the following chronic diseases: diabetes, COPD, heart disease, or end-stage renal disease. Their program was designed to see if frequent contact with such patients and close attention to their care and instructions would make a difference in the cost of their care and medical outcomes. Since CMS changed the way plans were reimbursed to a morbidity model, XL Health decided to form an HMO called Care Improvement Plus and to become a special needs Medicare Advantage plan. They contracted with our IPAs for physician services, and in October of 2006, they began contracting with agents to enroll patients into the new plan. XL Health had a list of 15,000 patients from their pilot project to convert to their Medicare Advantage plan. I had the opportunity to go with 3 agents on 60 of these patient conversion visits. The patients were very happy to see a nurse in their home several times during the prior year, and they still had continued to go to their doctors' offices routinely for examinations and treatments. The agents signed up more people for the new special needs plans than were on the list of XL Health. The spouse or other family members would also join as soon as they realized they could get the same care as their family member had been getting under the pilot program. The nurse's home visit and the attention of the company to the patient's problem was more important to them than their relationship with their primary care doctors. Patients were willing to join the program even if their specific doctors were not listed in the directory of the plan. XL Health was so confident of their own medical delivery system that they did not pay much attention to which doctor the patient consulted. They still have an open panel approach to their delivery system, but they have now outgrown their ability to see every patient at home several times a year. They are becoming an insurance company instead of a medical care provider. However, the start for them showed that personal contact with the patient in the home does something positive that no other kind of contact can do, relieving suffering, stress, and loneliness seems to help people to get well.